Good afternoon, everybody. Welcome to today's meeting of the Health and Wellbeing Board at the London Borough of Hillingdon. This meeting is being broadcast on the Council's YouTube channel, Hillingdon London. And for those of you who don't know me, my name is Keith Spencer and I'm the Managing Director of Hillingdon Health and Care Partners and the Co-Chairman of this committee. So just some housekeeping before we start, if I may. Please ensure any mobile phones around you are on silent. We're not expecting a fire drill, so if the fire alarm does go off, it is the real deal, and please follow officers out of the building. Really important point is please keep your microphone muted when you aren't speaking, and then unmute it to speak. Okay? Okay, we'll now move on to the agenda. Apologies for absence. Do we have any apologies for absence?
Chairman, we've had apologies from Julie Kelly and we've had apologies from Graham Call and Vanessa Odlin.
Thank you, Nikki. Declarations of interest in matters before this meeting. So, other than those already declared on the register of interest, do any members present have any declarations of interest on any matters being discussed this afternoon? No? Good. Thank you. Okay, let's move on to the minutes of the meeting on the 29th of November 2022. Does anyone have any comments on the accuracy of the minutes? No? If so, can I take these as agreed, please?
Okay, fine.
Okay. Thank you. And then just to confirm around the exclusion of the press and the public, I can confirm that items 5 to 8 will be considered in public and items 9 to 11 will be considered in private. What I'm going to do is I'm going to invite, just change around the agenda a little bit, if I may. I'm going to take item 6 first, just to give Kelly a chance to get settled. So I'm going to invite Gary to do the Integrated Health and Care Performance Report. Gary, over to you.
Thank you, Chairman. Just to a few sort of introductory remarks, really. There's obviously quite a lot in this report. As you see that there's actually been quite a lot of work being done to look at the future shape of the health and care system, and no doubt, Chairman, you'll want to embellish that. Linked into that is the next steps for the Better Care Fund. As you can see in the report, we're still awaiting the publication of the planning requirements for that. Again, as in previous years, the suggestion is really around us actually working together to shape that, and certainly within the context of some of the work that's now taken place on health and care system planning. Looking at the main body of the report, you can see really that we have actually managed to get through the winter. The system has actually managed to survive with partners working together, and you can see in there some of the performance that has actually helped to keep to support the hospital and maintain the system. I think I will actually leave it there, Chairman, and to open up for any comments that you may have yourself on the start of the report, and any questions that the board may have on the contents.
Thank you, Gary. I'll have a few observations. Any questions from colleagues around the table? Susan.
Thank you, Gary. Yeah, a very comprehensive report. Can I just ask, only because the sentence is in there, in para 12 it says the board is asked to note that Hillingdon Hospital actively includes people who are not resident in the London Borough of Hillingdon. Under those circumstances, do you know what the percentage is approximately compared to how many, because I know that we do suggest that we, at Hillingdon Borough and Hillingdon Hospital.
It is actually set out in the report. If you look at table 2 on page 14, that actually gives you a breakdown of where the activity, Hillingdon Hospital activity, is actually coming from. So that will actually be based on GP registration.
Thank you. Sorry about that, Gary. And one more question, if that's okay, through you, Chair. And on table 3, then, we're obviously we've got this explanation about how many people are coming through the A&E and how many are actually converting over to admissions. The numbers are quite high, through all of the age groups. And I suppose, for me, is there any sort of way that I know that we would talk about it forever about people turning up at A&E because they can't get to a GP or something just happens in that moment, and most of them are not the real accidents that people have to go to A&E for. But I mean, is there any provisional thought as to how we can actually start educating people around that A&E might not be the best place for you to go to? Question.
Okay, can I bring Patricia? Would you like to come in at this point?
So I think what you need to be aware of here is that the figures in table 3, and correct me if I'm wrong here, are the people who come through the A&E department, and because we have an urgent treatment centre on the front of A&E, actually the majority of patients who don't need to come to A&E are picked up through the urgent treatment centre, so that the people who are coming through A&E are genuinely people who need to come to A&E. We do have a proportion of patients who convert over from the UTC into A&E who might come in with chest pain, and actually it is a heart attack and they need to be seen. So actually I would expect our admission rates, our percentage of admission rates, to be high because they're the right people coming to A&E.
Ian.
So 2 things, and one is something that Patricia may want to comment on, is that I think it's probably worth noting that the running of the urgent treatment centre was changed significantly in this quarter because of what Anne said were performance issues. I'm not sure whether that's going to be put into next quarter's Health and Wellbeing Board report, but I think it's something that is significant and needs to be everyone needs to be aware of. I think the second thing is on table the discharge to assess pathways explained. You've got pathway 0 is 50%, pathway 1 is 45%, and we call these sort of P0, P1, P2 when we talk about it. But I wonder whether we've got any data on what the delay of discharge is within each of those pathways, because I think that would allow us to focus on what we could do to reduce the delay. But I have to say that Hillingdon has got one of the best track records for discharging patients in North West, if not the best. Even though looking at a table further down, we've still got patients who are staying in hospital longer than we would like.
Just if I can, before handing back to Gary, just to say, Ian, you're right, we perform very well on discharge compared to the other North West London boroughs, and we do collect the data on the P0 to 2 delays on the discharge. If board were interested in that, I'm fairly sure we could bring that to a future. It is part of our winter reporting. Patricia.
I mean, we do daily returns at a very high level of detail. The problem about it is it's very variable on a day-to-day basis, so how you might gather that in a way that was easy to present in this, I mean, we can have a conversation about it, but it's not all that easy to do. And just picking up on Ian's comment about the Urgent Treatment Centre, the Urgent Treatment Centre is commissioned by the Integrated Care Board. It's not a service that belongs to the Trust. and there was a decision made by the Integrated Care Board that the service should transfer back to the hospital. It's a transfer back to us as part of what's an allowed emergency measure. It's not that we've been awarded the contract, and we are maintaining that service. I have to say that we're maintaining the service with predominantly the staff who were working with the previous provider, and that is working well at the moment. And we did a transfer at very short notice.
Tony?
Just back to the point, what may be useful is knowing what the sort of putting them into sort of categories and numbers of bed days in order to identify whether there are things as a system that we could do to unblock and unlock, because I could probably think of a couple of the causes off the top of my head as to what they would be. So again, it'd be quite useful to flush that out in order that we can challenge that as a system.
Gary, is there anything further that you want to add on the report? I've got a few observations, just summaries, but anything else you would like to add?
No, Chairman.
Okay, so if I try and summarise this, and just from my reading of the report, I think there's a couple of points I think we just need to bring out because they're really important. I think points, and it's your opening, almost the opening paragraph you've got there. There are many things we do well as a partnership. We've done well on the discharge front. We are one of the best in North West London. We need to do better in terms of our ED avoidance. That's clear from the front of this. To meet the requirements under the new hospital redevelopment, we need to do even better on discharge, particularly those who stay longer than 21 days. But I think the thing that comes out of this, and I guess we will have to come back to it at some point in this meeting, is the recognition that certainly from a health perspective, the place has a significant financial deficit. And that until we can make inroads into that financial deficit, it's your final bullet point on this, Gary, I think on the front page, it's unlikely that any significant delegation to place of budgets will take place. So what I can say on behalf of the partnership, and I'm sure Jane will hold me to account in this when she's chairing in future meetings, all of our work is focused on what we do to move the needle on the place-based deficit. And when we talk later around the transformation work we've been doing, it is focused on how we move the numbers in some of those areas, because it is a key issue for the place. And I think it's really important that we as a board really understand that is a really big issue for us to tackle. The other thing I would just say, finally say, and it may well be, Gary, that you and I can talk about this after the meeting. I thought this was a really helpful report. I think it would be even better if we could add on key components of it, is what we're going to do about it on some of the issues, because obviously we register it as an issue, and I think we just need to probably be tighter on what are we going to do about that. And I'm quite happy to take that as an action, working with colleagues outside with my managing director hat on, just in how we strengthen that. But I think it is a good report. Tony.
Can I just check? Might be, if it's too much detail for now, say so, and I'll be happy. In terms of the deficit point, then, is there a tolerance, or is it a? Because presumably it's not zero. And if there's a tolerance, what is the tolerance? And if there isn't there a danger that you never reach it because it enables somebody to be able to say, well, if it was X instead of Y.
Go ahead, Patricia.
So I think what's very helpful in the way Keith's framing this is that do we look at a deficit that sits with the hospital, or is it a deficit that sits at place? And there's an increasing narrative that the deficit needs to sit at place, that it's a health system issue. The fact that there's a deficit being reported at the trust doesn't take away from the fact that we've got efficiencies to make, we should be more productive than we are, all of those sorts of things. but actually there's quite a lot of what's in our plan is outside the control of the trust. We don't control who walks in our A&E or whatever. The discussion that is actually going on now is that the money is allocated, so the health money is allocated to the ICB, and the tolerance sits at the ICB level, so the ICB is expected to put in a balanced plan, and that is what the ICB expects to be in a position at, by year end, and we're currently in negotiation across the whole of the ICB, not just the acute providers, about putting in a balanced plan for 23-24. So it's starting to be nuanced a bit more in that the Acute Provider Collaborative, which is the 4 acute trusts in North West London, are going to be expected to put in a collective balanced plan, although individually we may hold deficits in different bits of the individual organisation. So our statutory position may be a deficit plan, but the statutory position that sits at the ICB would be a balanced plan. So that's how the tolerance is worked out. And the mental health trusts are doing something similar. And then there's a balance with the CCG budget. So it is still, in theory, well, not in theory, it is intended that the ICB will put in a balanced plan for next year. And what the ups and downs look like will be within individual organisations, but overall it will balance. And well, I should add to that then the negotiations we are having with the ICB, for instance, at trust and place level, is what is the allocation that should be coming to us based on the normal calculation methods, but other things we know historically or we know about pressures that are specific to Hillingdon that we are saying actually we should be compensated for that or whatever. So that's the negotiation that's going on at the moment. And as I think this committee knows that the trust is what's known as SOF 4 or now NOF 4, which is where we're under a lot of scrutiny around our financial position, that actually we've been able to demonstrate through this year an improvement in our financial position and our understanding of our financial position. And one of the things that we're discussing with the centre at the moment is whether or not we stay in NOF 4 or we move to NOF 3, and that better understanding of our financial position is making it easier for us to negotiate what our position should be for next year.
Sorry, it's a thank you. And does that address? I'm sorry, I don't know if I'm asking you. It might be Keith, might you? Does that then address? Because we know that there's the kind of historical sort of deficit point based on funding formula and so on and so forth. And if it's still the same, when we were doing the heady days of the STP and so on, there was, we knew that if you added it all together, divided it by the number, you still come at a minus number. Well, do you see what I mean? So, does it ever get to a sufficiently balanced point if that's still the case?
Can I put this up, Tony? Because I think the way I guess I am trying to frame this as a place-based issue. So, and I will come on to your answer in a moment, but what we've just done, what the strategic finance leads have just done in place, is unpacked that deficit, looked at the root cause of that deficit, so we can be clear where accountability for various parts of the deficit sit and who needs to do what as part of that. And the piece of work that we have commissioned jointly across the place is basically to look at how we get to a place over 3 to 5 years where we balance as a place. What is the plan? What is the trajectory that gets us to balance? And I believe that's the key to unlocking discussions with North West London, because it's starting having a clear plan and starting the journey, which is important. Getting there is important too, but actually having a plan and starting the journey is equally critical too. So a 3 to 5 year plan which gets placed to balance and where we're clear where the accountability sits. Because as Patricia said, significant proportion, 50-60% of the plan, requires the hospital to make efficiencies. There are other elements outside their control which requires us as a place to do something, particularly around demand management and other. So we've unpacked them, had a really good discussion about that, and I've commissioned the work to help us on that journey, because I think it's really important that we don't delude ourselves about the scale of the task that we face. Here, just to do that, because our hospital is clearly part of our place. and North West London rightly see the hospital as part of that place. So that's where we are, and I think what I'd hope to be able to do is to share that plan once we developed it with the Health and Wellbeing Board, so we can see where we sit on that journey. Ian.
So I think we tend to focus, and possibly a criticism would be we overly focus on the money side of things when we need to think about what the impact is on our patients. And I think what we're seeing at the moment is much more increased pressure and expectation from what patients expect the NHS to deliver at the moment. Whether this is a backlog from COVID, whether COVID has caused more morbidity, but certainly both in the primary and secondary care sectors, the expectation and the demand from patients is greater, and that's leading to sometimes justifiable frustrations. It's increased. We've still got quite a backlog, both in secondary and primary care. The numbers in primary care in terms of nurses and other clinicians is quite low and is falling, particularly nurses. So we often talk about the doctors, and I think in Hillingdon we've got quite a high level of GPs over the age of 55 who will be retiring in the next few years, and we need to think about a proactive plan to mitigate that as much as possible. We know that one of the most startling figures that we've heard is throughout London, of all the GPs who trained last year, only 50% of them are going into general practice as a proper patient. The others are either not going in at all or just doing locums. So there is a clear workforce crisis. And the other side of the story is that we are, as a public health measure, and as part of the 20+5 programme, looking at trying to find those areas where there are health gaps and deficiencies, particularly things like high blood pressure, where we know that probably 50% of patients with high blood pressure are going around undiagnosed, and about 50% of those diagnosed are not fully treated. And that adds to the workload. But the other side of the story is if we don't look for those, they'll just come in as emergencies and create problems. So it's a very complex area, but the bottom line is that the demand and expectation on all the services in primary and secondary care is much greater than it was pre-COVID, and that's causing real pressures.
Thank you. And just before I bring Tony in, just obviously we had a presentation to the Health and Social Care Committee a fortnight ago, where Dr. Prasad presented some of the primary care data, and clearly over the last 2 years there's been an increase around 7% in GP appointments in that patient. Just supports what Ian has said, just in terms of the pressure that we're facing on primary care. At the same time, having to face the financial challenges that we've got. Tony.
Sorry, just final point. Just agreeing with you. So what you've said in local government circles, the nutty phrase that's around is that the money's gone, the expectation has stayed, and it's exactly that. So we've got a whole hump of activity that happened through COVID that isn't going away in the way that we expected it to go away, and actually then and then that's compounded by the expectation that's born from that was received during that period by others now receiving it. So there is, across the system, actually there's a whole point that we probably need to unpack at some point.
I'd agree with that, Tony, and I think the key thing is, if I can put even finer point on it, carrying on as we are isn't really an option for us, and I think that's the reason why we need to think about how we transform services. But again, I'm sure we'll come on to that a little bit later. I'm going to draw this part of the discussion to a close, I think. Thank you, Gary, for presenting that. What I'm going to do now is move back to agenda item 5. I think, Kelly, you've had an opportunity to get settled, and welcome. Would you like to give us the public health update, please?
Thank you, Chair, and apologies for being late. It was snowing. So this public health update is in the context of just focusing on the 2 pieces of work that we presented late last year, particularly one around a whole system approach to obesity, and the second improving uptake of NHS health checks. And from a starting position, I'd say one has progressed more than the other. So starting with a whole system approach to obesity, at the previous meeting we spoke about a real focus on Hayes and looking at a place-based review of what assets we could mobilise and how we could engage with stakeholders and communities, specifically within Hayes, because that was the area of the borough which had the highest prevalence of people who were either overweight or obese. And we also identified it as a location where people identified it as a community, so Hayes Town specifically. We felt that the national direction in terms of the guidelines about how you conduct a whole systems approach would best fit a location which was sort of geographically defined and people would identify with. So, as mentioned, the board received a report that set out sort of a project initiation document and a rationale as to why Hayes was the chosen area. And the idea was to then pilot this national approach to a whole systems approach onto that location. So initially we have set up a core team. It's fundamentally a public health core team that's allowed us to try and put the foundations in place and try and lay some sort of structures so that we could then build on a sort of a framework for really understanding that community. So, and then start thinking about then how do we build on that sort of local data and local insight to start engaging with the community. So there's initially been some sort of initial sort of insight work and some Hayes orientation that we've called it, which is sort of aligned to the terminology in the national document that starts with identifying sort of assets and who are the stakeholders within the community, particularly in amongst sort of faith communities and targeting those communities where we know that the incidence of also the prevalence of obesity is greatest, and those communities where residents are less likely to engage with services. So we particularly focus on the sort of South Asian communities through their faith settings. And we've also started to sort of, in terms of a pincer movement, not only thinking about the adult population but looking at the child population. And this sort of work has coincided with the submission of expressions of interest for what we refer to as the schools super zones, which is about creating sort of a healthy surrounding to schools, which allows sort of active travel becoming the sort of the fundamentally easiest option for schools. And we've submitted 3 bids. One of those bids has been successful so far, and that's in Minute School. So that kind of allows us to really sort of focus on not just that whole systems pilot of place, but also thinking about that sort of that system as in that sort of school infrastructure around the school. 2 other expressions of interest we're sort of waiting on to determine. So that's in sort of the initial work. We've built that rationale and built that framework, but only fundamentally in terms of the headlines. At the end of this month, we'll be having a workshop with the community and with stakeholders in the community. And last week we sort of exercised how we would respond in terms of sort of role-playing that sort of opportunity of who is likely to attend, what would be their rationale for attending, how do we engage with those different sort of stakeholders in the community, and be able to sort of aim not just to get their buy-in, but that sort of sustainable long-term engagement that allows us to really sort of build the assets. And thinking about that sort of asset-based community development for the long term is how do we mobilise what we know exists, but also how do we identify those parts of the community that we are yet to discover how they contribute, and thinking about how do they become more visible, and how sort of do we build them into a sort of a wider systems map, and thinking about people's experience of living in that location and what are the challenges that they perceive as, is it access to healthy food options? Is there somehow sort of a challenge of sort of limited ability to sort of for children to walk to school, or perception of safety? But it's about really sort of understanding what their lived experience in that area is, and start to think about from a different perspective what is the likely sort of situational analysis we can think of that helps us think about in a different way about what drives unhealthy weight within that community. So as part of that process at the end of the month, we'll do that engagement piece of work. We're going to build as part of the ask, it's about building a reference group with the community, and then there is a sort of short, medium and a longer time piece of work in terms of how that community can start engaging and how do we work together. And it very much builds on the sort of the population health management approach in terms of segmenting, identifying the communities at risk, and then working with the community to come up with interventions and sort of options for a solution. And at the same time thinking about how do we evaluate those options, what's meaningful in the short and medium and long term, and how can we determine whether what we're doing differently is having a real impact. So as I say, work in progress. We expect that sort of initial piece of work, say workshop at the end of March, the end of this month, and then over the next 3 months we'll build that reference group and start thinking about the interventions that we'll put in place. The second piece of work is we talked about was NHS health checks, and this is a mandated core element of the of public health. It's a national screening program that we must deliver. Our GPs deliver this program for us, and when Becky spoke about this piece of work previously, she spoke about sort of the importance of it, particularly in relation to identifying long-term conditions, particularly as a useful tool in terms of sort of that rising risk population, and the real importance of a high uptake of NHS health checks to get people to understand their risk, but really importantly the so what factor. What then happens afterwards? Because identifying risk of a sort of a long-term condition is great, but actually it needs some sort of degree of intervention in terms of mitigating that risk and getting people to take some ownership of some of their health risk in terms of sort of creating a sort of a healthier future. And part of that, what she spoke about is sort of how do we engage with GPs, how do we reduce GP variation, and she spoke about how she worked with different GP general practices in order to look at how they can target different communities. And Hillingdon is no different from many other places. There is clearly those people that attend for an NHS health check, and there are those communities that don't. And it is those communities that don't that we're particularly interested in, because if you look along sort of epidemiological data, they are the communities that are most likely to be sort of have those long-term conditions and the least likely to actually sort of attend for any intervention that can improve their health. And also part of that work, so she and Sunny have been out and about doing blood pressure checks and reaching out into the community to start trying to understand why people sort of attend for services and why they don't attend for services, and start sort of piloting a sort of a community outreach as a sort of prospective view in terms of how do we deliver health checks more effectively in the community, and reaching into those communities where, as I say, they are least likely to attend their GP and get their routine health check. So in terms of our uptake, we're good at inviting, and two standards that we have is to invite people for a health check, and people get invited once every 5 years. So that's on track. Unfortunately, the health check uptake is less than 50%, and if you look at sort of different communities, and we're looking at that data in terms of trying to be a sort of bit more accurate about the sort of ethnicity as a sort of a proxy measure for uptake, there is some difference in terms of the rate of uptake by population size amongst different ethnic groups within the community. So we're trying to think about how do we get that data more robust, and then what action do we take. So in terms of that kind of current piece of work that she's doing, it is working with general practice, it's working with the GP Confederation, and it's starting that resident engagement in a similar way to other areas have done, to really think about how do we get buy-in, how do we get people who are, as I say, at greatest risk to attend for their health checks, and more importantly, once they've had their health checks, that they actively seek out or sort of take action that supports them into a sort of a healthier position for the future. Happy to take any questions, Chair.
Thank you, Ken. I'm going to give the first question to Jane.
Thank you, Chairman. It's probably not a question, but I just want to say thank you, because for the first time in a long time I can see some really good health work being done in a specific community area. And I think that is something that this borough really, really welcomes, and I hope that the residents of Hayes will engage in this. So I suppose I'm always interested in evaluation. So with weight obesity, I suppose the evaluation is how much weight has been lost. is probably the cold response, but there's much more to it that, so I'm quite interested in how much you've looked at, or the team has looked at, an evaluation in its entirety.
So I think one of the things, Councillor, that we are trying to measure is what are the measures that the community would recognise as important to them. And traditionally it's been whether people have lost 5% of their body weight from a starting point over a defined period of time. But actually part of what we want to do is think about what are the other measures that people would find important. And obviously we know that a healthier weight and the sort of the measures by healthier eating, being more physically active, has sort of wider health implications than just weight loss. It's about feeling fitter, about feeling sort of having a sense of greater well-being. So one of the things that we are looking at as part of that stakeholder event is to think about what does the community want to determine as its measure of success for some of these areas, because traditionally we would have said it is just about a healthier weight. But I think Councillor Bryan, sort of months ago when we spoke about it, we spoke about the perception of being fitter, and just losing weight is not necessarily a measure of whether people are fitter, because we know that muscle weighs more than fat, and so I tell myself every day. Yeah.
Oh, go on.
Thank you, Chairman. It makes sense. Personal experience, not personal experience, residential experience from constant emails coming out of doctors. There's been a wave of it where I am based about you've been to the doctors recently and you are on the obese. And when the residents have gone back, they've been told there's like a 13-week wait before they can do anything, so it's pointless. So when we talk about not engaging, I think that is one of the reasons. I'm not a big fan of sending out a text, and then when residents go back to accept that they want to do anything, they're told, well, there's nothing we can do, because for me that's just ticking a box that you've consulted your residents or you've done something that you're expected to do. So I would want people to take into account that sometimes it's not non-engagement, it's the fact it's pointless, they've tried, and in 13 weeks it's only going to go one way. Sorry, that's just an observation.
So, Councillor, one of the things that I would say is that actually we do need to look at sort of more sustainable ways of getting people to be more active and to look at interventions wider than what their GP surgery offers. And I think that some of it is about, we have fantastic parks and green spaces within the borough. Are we active? Are we making the most of them? And since May last year, Priscilla Simpson and her physical activity team has been working within public health, and actually the scope of the work that they're doing to get the communities more physically active, particularly sort of groups like South Asian women who have been less likely to have become physically active, and really target those groups, and looking at sort of sports venues and how we sort of successfully get grants to make sure that the sports venues are affordable, if not free of charge, and how those communities that we most want to tackle where unhealthy weight and physical activity is a real problem, have access to those community spaces. So we do need to think about what are those wider assets within our communities that perhaps we just need to sort of think about using more effectively, because most of them are closer to closer and more accessible than a GP surgery. And I suppose thinking about what Dr. Goodman has said is, the impact on general practice at the moment is huge in terms of just the sheer weight of numbers, and actually to think about what is those wider preventative and early intervention measures that's wider than the NHS, because fundamentally, we're in a kind of a pressure cooker at the moment, so we need to think more laterally.
Just before I bring Patricia in, can I just take Chairman's privilege here? And it's a question either for Eddie or for Kelly. I really don't mind. But obviously what we're talking about fundamentally here is around anticipatory care, proactive care. We've seen from the ED data, 49% of people who come to ED have an underlying condition. Hypertension, obesity and anxiety are the top three. This work is being integrated into the neighbourhood development work, because obviously it's got to have a rooting in how we do. I don't know whether this is an Eddie answer or a Kelly answer, really.
Yes. Then there will be greater links. I think it's fair to say that we haven't exploited those synergies just yet, because fundamentally particularly that whole systems approach work is very much in its infancy, and what we want to do is really get some community buy-in first, and then obviously sort of linking into those integrated neighbourhoods will be key. Is that fair, Eddie?
Yes, it is fair, but there's I always come back in my head to the elephant analogy, and it's a big thing, but you've got to start somewhere. And I think the point made earlier about hypertension and actually working as a neighbourhood. I think the neighbourhood working and the purpose of the neighbourhood go hand in hand. So if you gather people around a purpose to improve detection and then treatment of something like hypertension, you actually build the neighbourhood around the solution that you're trying to achieve, and they're sort of mutually sort of beneficial to one another. So I think neighbourhood working will coincide with some of the projects we are initiating around things like the detection and management of hypertension in neighbourhoods and in communities. So I think the two things go hand in hand, and so part of the neighbourhood agenda is to actually identify the priorities and actually initiate some of the action plans early doors.
Ian, is yours related to this one? I will come to you, I promise, British in a moment.
So, for Councillor Palmer's benefit, to put some context about this weight issue, the NHS has quite rightly incentivised GPs to identify those patients who are obese. But in the way the NHS works, it's only approved a certain group of organisations that can actually provide this care. So that unless a GP refers the patient to that organisation, they don't get paid for it. So this organisation is clearly going to be overwhelmed, and there are, as Kelly said, there are so many different ways to tackle the weight loss that it causes unintended consequences that possibly we can think around as an organisation. And I think we've talked about how we can change patient behaviour, and clearly if it was easy to do, we'd have done it by now. But I think this integrated neighbourhood working is going to be the way forward, because we've got to break that link that the patients think they have to see a GP for their ailments, and an integrated neighbourhood process where other organisations and people in that neighbourhood who aren't necessarily clinical, don't have to be clinical, can address the very basic public health issues. And in fact, we've won a bid as part of the inequalities funding to set up what we call community champion working. And there was a meeting yesterday. I think Sandra was at it yesterday. Were you at the meeting yesterday? No. Anyway, there was a meeting yesterday that we had with various members of the local authority to set up these networks of community champions, very much built on what we did during COVID, and using that experience to go around into neighbourhoods and develop a programme of health improvement and health education, particularly in those areas of greatest inequality and need.
Patricia.
Thank you. So if I might make an observation, then I had a couple of questions. So some of this feels very deja vu, because the sort of whole thing about tackling obesity was stuff that, as a PCT chief executive 10 or 12 years ago, this is exactly what we were focusing on. And my particular experience was in Kensington and Chelsea, which people will say, you know, nothing like the outer boroughs, but actually there's huge diversity of population in Kensington and Chelsea, and a huge problem with obesity. And one of the things we did then, which I think there was some really good learning from, was actually almost to use like an advertorial type approach, where we went out to local communities and said, this is an issue, if we do this for you, what will you do for us, kind of thing. So it was a trade-off. And we ended up with some really, really good success. I mean, the particular example I have was around dental uptake, but we did a lot around obesity management as well, where it was less about medicalising the problem and more about saying, what are the things that are different about your community that mean you eat in a different way or you exercise in a different way. And that led to a number of interventions like cook and eat programs, because we realised that people actually didn't know how to cook lots of different foods. So, you know, they don't know how to cook more healthy food. And that had a kind of dual benefit, because we had some older people who were actually quite lonely, who hadn't got their lunch clubs anymore, who came and cooked their lunch and ate it, but they also learned how to cook more healthy food. But we also had a lot of people from different ethnic backgrounds who were only used to cooking a particular style of food, and learned quite a lot from that. So I think there is maybe some benefit about doing more of that work about what do communities want and how do you tailor the programs. The two questions I had really are, in both the work you're doing on obesity management and the work you're doing on health checks, what work's been done on how you can use digital to make a difference? So again, a couple of examples. We did some work with children where they were doing work in schools where they all had an exercise or an activity app. And, you know, even in the most deprived areas, they often have access to a mobile phone, or you can get devices. But it was a competition about how many steps they walked to school. They had these pressure mats that you can step on. And then they got, as they walked into the school, they got their scores on the board. And that had huge impact in terms of changing healthy behaviours. So I think there are, and they're, you know, the digital apps are so much more developed now than there were. So I think there are some relatively low cost options around digital that I think we could use potentially much more. And then the other one was around, within North West London, we are part of the Digital Health Accelerator for London. So it's a London funded programme, and Ian is aware of this as well because we both sit on the digital board. And there is a lot of technology around now about doing health checks, and particularly health checks in community environments. And I just wondered what work there's been done to look at whether or not there are any of those programmes that could be used, and just introduce. And there are companies that are desperate to get them into community settings, and that would be a way of doing more health checks more rapidly.
So two things is we are looking at digital, and particularly around those who are likely to be more motivated to help themselves, and recognising that those who possibly we most want to target are those probably that are least likely, but we need to move them into the space to motivate them. So in terms of this sort of digital health work for NHS health checks, that's part of the NHS health checks programme. So that's actually coming in line. I don't know enough about the detail because slightly digital slightly turns me off, really. So technology and me are not happy bedfellows. But Becky is really, really onto that and is looking at sort of how do we implement that locally, increase uptake, greater access, and the benefits that will come from that. In terms of digital apps, so we have been looking at a number of apps, particularly around things like Better Points. There are obviously the ones that have been sort of floating around for a long period of time, like Beat the Streets, and others do exist. And thinking about actually how do we work with schools, particularly around those school super zones, and thinking about how do we generate some momentum behind those sort of school super zones to see whether actually there is some real appetite for change, and particularly some of those apps have real benefits in terms of incentivising activity. But again, going back to the sort of the council options, we have significant amounts of physical activity that we offer, much of which is not through community connectors and community sort of champion people, but actually there are sort of people who have gone through various programs who are now sort of leaders of different groups, particularly cycling groups, walking and running groups, so actually building on that. But the digital option is always something that it's high numbers, relatively cheap cost, and sort of very accessible given that everyone's now got a mobile phone. Yeah, but good point. And it'd be useful to pick up on that Kensington and Chelsea work to see, because one of the things that we really want to drive is in the same way population health management, sort of that circle. It's about what does the community perceive as the barriers, and what does the community perceive as the solutions as well.
Okay, I'm going to give the last word on this subject to you, Susan.
Thank you for allowing me to mop it all up. I'm encouraged. I'm going to stick with the young people and the children. So I'm encouraged that we've got these school super zones. I'm encouraged that we've got a school already signed up. And I'm even more encouraged that we've got other schools wanting to follow on in those footsteps. I mean, for me, it's really important. I know we've discussed this already. I want to really move away from the target zones of you're told when you're in reception that you're overweight or you're underweight, and then you're left for 6 years until you're leaving the school and they give you the delightful letter to say your child is obese or your child is underweight. So I would love for, in the middle of all of that, for us to be able to get to the nitty-gritty and start working out with children, obese or overweight. Let's just find that healthy weight. In addition, delighted, and Patricia, thank you. You brought up started the conversation around the dental work. I would ideally love, and I'm assuming if we can pick this up offline as to what we are doing, but dental nurses making sure that they can start going into schools, not just being within the children's centres or in hubs and things like that. That would be really useful. I know it's difficult to get dentists into schools. I'd be delighted if we could get some dentists going into schools as well, and just having those conversations, not just with the children, but hopefully with the parents. And I'm hoping and praying that every bit of toothpaste and every toothbrush that's sitting in a cupboard somewhere is actually going to come out and actually be handed out to children so they know how to brush their teeth. Thank you. I'm encouraged. Let's go for it.
I'll just respond back to that, Councillor. Wise words. All the things that you pointed out in terms of poor oral health, that is a really a key problem that's been perennial in the borough. There are so many interdependencies between poor oral health, decayed, missing and fill teeth, our poor outcomes there, and the need to be more ambitious in the way that we tackle that, rather than just sort of thinking about supervised toothbrushing, which is what we do, but that's not the panacea. The panacea is very much prevention and getting parents very much engaged, accessing sort of dentists before the age of 1, thinking about actually is it a water-only offer in nurseries and schools, or milk offer in nurseries and schools? How do we reduce the sugar content in sort of foods that we provide through schools, and in terms of the fizzy drinks? And as we progress, that access to cheap fast food that's high in sugar. So actually much of those things about how do we change sort of obesity tackles a whole load of wider health, particularly child health issues that can be driven by many of the decisions that we through the board and through sort of our sort of politicians can really drive forward. And actually, as I say, the interdependencies between all of that are really, really clear. And I think Sheikha presented what was kind of like sort of slightly sort of nauseating picture in terms of that sort of line diagram that shows sort of circle upon circle upon circle. But actually, while that's difficult to look at and incredibly complicated, what it really, really does stress, if you tackle one area, it opens a sort of turn a stone over and there's another issue behind it. So actually, if we are really going to make a sustainable difference in the long term, all of these things will be tackled if we have kind of a strategy and a real understanding of, by dealing with one, what is the knock-on consequence, positive and negative in many of the other areas. And some of that is a building about infrastructure, is thinking about how do we educate parents, and is thinking about sort of how do we ensure that where children are, that option to what's healthy and what sort of protects their teeth is primarily the easiest option.
Okay, thank you for that vigorous and healthy discussion. So I move that the discussion be noted. Do I have a seconder? Good. All in favour? Yep. Fantastic. And before Jane corrects me, I missed doing that on the very first agenda item. So for the match of the day highlights this evening on YouTube, I'm sure they'll edit it out. But for the Integrated Health and Care Performance Report, I move that discussion be noted. And do I have a seconder? Yes. All those in favour? Great. Fantastic. I look forward to Gary Lineker's comments this evening. Okay, can we move on to agenda item 7, which is the Thrive update. Jane, you are very welcome. Jane is the Head of Joint Commissioning for the North West London ICB. The floor is yours.
Good afternoon, everybody. I'm going to start off with an apology. Due to some slight editorial technical issues, there is a section of the paper that you don't have in front of you, which was actually sort of added to the piece that I have written from my colleagues in CNWL. So what I've agreed with Nikki is we will share that, and that section was sort of, I think, giving a little detail of how and what CNWL are doing around the Thrive agenda. So you asked me to come to update you on where we have, and I just wanted to remind everybody, I think implementing a Thrive or a thriving needs-less system is actually a very ambitious plan. It requires a significant change in approach and sort of cultural attitude to young people's mental health and emotional well-being. And I don't say that to stop us doing it, but I think I say that to recognise the work that needs to happen over the next 6-9 months, perhaps even longer, in order to embed that system within our young people, within the system that we offer to our young people in Hillingdon. So I've reminded everybody on the top, I think the service, I've talked about the service mapping that we've done and given you some I think the nice little diagrams give you an idea of what it is we're trying to achieve. And the elements, the idea was where this started, I think, was it was felt that the old tiers model really sort of suggested you were trying to climb a ladder, and each time you got to the top of the ladder, rather than fall off, you were moving up to the next tier. What we're looking at now are segments and moving around. I think there's some interesting work to understand how and when that happens, because what we don't want to do is, by using a different model, create a different set of hurdles or challenges. So we have been looking together to map what happens in Hillingdon, so what is available for our children and young people regarding mental health and emotional well-being. And I use those phrases very specifically because I think an awful lot of us will refer to mental health, and mental health is CAMHS. And actually, when we look at what a young person is anxious about or what they're worried about, it may well be that they're emotionally distressed rather than mentally ill. And I think that's true for adults as well. So we have been working collectively, and it's great to be working with both P3, one of our local voluntary organisations, and Health Watch around completing the mapping. So we've held now 2 workshops where we've pulled together everybody who has a role or a service that offers and covers that area to try and so that we can see what's available. I haven't shared the diagram that is, but it's a very, very busy map or picture of all of those segments. And what we're doing at the moment, I think what we've recognised is even within sort of the use of language means that one person's getting help is somebody else's getting more help, or the language we use around assessment means very different things. So trying to get to a collective place where people working in the system understand what different services offer and where and how they fit. We have identified, even in those conversations, some gaps, and I think as Kelly was just talking about, there's some short, medium and longer term things to do. So in the very short term, voluntary sector colleagues have recognised there is a real pressure and request for young people for more peer support and also more parenting support, and are agreeing to work together to understand, well, what do you offer? How do you offer it? Is there anything we can do and learn from each other that would increase that capacity around peer support for young people? I think increasing capacity is really important at the moment. The other concern that is raised, I think, is this concept of where somebody of families' needs not fitting the criteria for the specialist community CAMHS service. And we've agreed to do a more detailed piece of work to understand look at some of the cases of those families and young people, to understand what is it that we then need to put in place to meet those people's needs, rather than them feeling they're going around through a revolving door. If you look on the page 2 of my diagram, I'm not sure what page it is in the report, but you'll see there's a second diagram, page 26, and I think what I've done there is really show where we are in developing the Thrive system in Hillingdon. We really are up there, set up and governance. And it's great to see so many partners willing to join with us in order to sort of get that really good picture before we move on to, the model suggests, the structural features of implementation. It's interesting listening to the work that Kelly's doing, because I definitely feel there's some resonance around similar types of approaches and similar methodologies, and using evidence-based practice to help inform what we do and what we're trying to achieve. So, as I say, sadly I can't share, I can't go through the detail that CNWR colleagues have shared, but what I think, and we will do that separately, but I think what they wanted to say was they are also part of this journey and are very keen to shift their model of delivery from making sure that young people see the right person at the right time for the right amount of time in the right place. And they have shared some of their they shared some of their activity data and their referral data, which continues to show the level of pressure that we're seeing in our system. There is now national data that the impact of COVID on young people has meant that we now see 1 in 4 of our 16 to 18-year-olds with a diagnosable mental health condition. Prior to COVID, that number was 1 in 6. What I would also say is, and why are those young people emotionally distressed, or why are they mentally unwell? It's really important that we understand, because I'm anxious, the question I think to ask is, why? What is it that we need to assist you with, that we may be able to help you with managing your anxiety? It may be relationships, it may be bullying, it could be housing, it could be your family circumstance. But I think the medicalisation of that would see us offering medication. I think it's really important we look to what are the root causes for young people. Lastly, I just wanted to say that one of our population health management projects, which will support us in Thrive, is our aspiration to have a new single front door for young people. Not only for children and young people's mental health and emotional well-being, but I think we would really like to see if it's possible to do that for all young people services, to make it easy for families so that they don't have to tell their story more than once as far as possible. And we're sort of setting up conversations with colleagues in local authority, within children's services and also within the SEND area, to look to see how and CNWL, to look to see how we can make that happen and to put together a plan for how we do that. I will leave it there, but happy to take any questions.
Jane, thank you for that, and thank you for stepping in at the last minute too. Colleagues, any questions? Susan, yes.
I just have, so I tend to ask questions that people can't necessarily always answer. So we're in phase 1. What's the timeline where we think we can go into 2, 3 and do full circle?
To do my mic. So we're currently planning the next meeting in April, where I think we're hoping to come up with that final plan of these are the services that exist in the moment in the various segments. And then we've done an initial piece of work where we assessed where we think we are, where we think we're good, where we're not good. But we really wanted to test that again to help us really to make sure that we pick up on the areas that we want to focus on. Where we're good, we want to just acknowledge that. What we really want to understand is where do we as a system think we need to focus the effort on. We're not quite there yet, but I think that may take us a little bit of time to really get identify the right issues, and then to pull together the right teams to help make that happen. That may now need funding, but I think people are definitely committed to do what's the right things.
Patricia.
So it was just an observation, really, that in North West London ICB, part of the strategy is to set up a research function within the ICB, or strengthen the research function in the ICB. And there's been a group meeting for the last 6 to 9 months. And we've agreed now on essentially 3 programmes of work, one of which is children and young people's mental health. And I think it's just really important, when this is already ongoing, that we need to make sure that we feed into that research work, but also make sure that if there's research money coming, that it's used to help further this work, because I think there's a huge opportunity there.
So the Children and Young People's Transformation Board in Hillingdon, I think, has had a presentation from the people who are leading or working on that part of the research programme. So absolutely keen to learn from and feed into and make sure we access any resources. The front door model I mentioned, actually what we've been asked to do is to do a 2-year pilot and prototype that for North West London. So it's and I think it's great that Hillingdon is I think I've been told recently, ahead of the game in terms of Thrive. I'm not sure if that's true, but I think they feel our partnership working across the local authority and also with CNWL puts us in a good position to make that happen.
Kelly.
Jane, I'm a really big fan of this one, and I know that Thrive isn't new, and where I was before, Northamptonshire, mental health trust, they were implementing it. I just wonder whether, as part of the process, we have, seeing as you live in Northamptonshire, whether we've reached out to those particular areas that have been an early adopter of this in terms of what benefits, what pitfalls, what could we learn that means that we're even more ahead of the game so we don't fall into the same traps.
We fortunately have the new director for children and young people and eating disorders in CNWL and the deputy. Those come from Northamptonshire. So I have taken advantage of that and their links and made contact with the Children and Young People Service lead in the county to see if we can poke their brains as to what worked and what didn't, and also looking to other areas too.
That was a CQC outstanding trust in terms of, and predicated much on that for kind of very innovative work. Thanks, Jane.
If there are no more questions, I've just got one question, Jane, and you can duck this one if you like. In the light of this, because reading this through, obviously we prioritise in terms of our transformation initiatives as a place. We prioritise largely neighbourhood development and some of the adult services. Is there a case, do you think, for us for rethinking, significant rethinking, the children and young people's transformation? Do you think there's a real case for having a good long look at that? So I'm happy to duck that question.
Yes. I absolutely do think it's something we should look at. I think through the Children's Transformation Board, and Kelly's organising, I think, a workshop for our next meeting, we have a lot of things happening that I think we really need to harness the opportunity to look at the variety of hubs that are being set up. What should we do? There is increased investment coming through for children and young people's emotional and mental health and wellbeing, and I think Hillingdon was regarded as an area that was underfunded in that area before, and I think we need to make sure that we make best use of that resource and make sure that it gets, and it I think also addresses the needs of young people who don't come forward early enough. We're seeing a lot of, we have a lot of young people who turn up in the hospital in crisis, and I think this project also needs to look to see what is it we should be doing for them that would offer support earlier and reduce activity. So I for what it's worth, would recommend that, yes.
Thank you. So I saw a lot of nods around the table when you made that answer, so it was clearly the right answer. Any other questions or observations people want to raise on this topic? Well, thanks, Jane, for that and for encouraging that discussion. I move that discussion be noted. Do I have a seconder? Yep. Let's assume everybody's in favour of that. Yes? Good. Thank you on that. So thank you for the Thrive update. I think that moves us, I know that moves us on to agenda item number 8, which is the board planner and future agenda items, which we have attached to our papers. And I notice I've become Caroline Morrison. Again, that's okay. Doesn't matter. No comments, please. Thank you. Any comments on the board planner or anything people would like to see added? I think. Right. Okay. You were marginally first out of the traps, Gary, before Tony. So Gary, you first.
Oh. Well, it's been a pleasure. I was just saying there's a possibility that it might be bringing the next iteration of the BCF plan to the June meeting. So if we added that, we could always slip if necessary.
Okay. Tony, you were next. Think then I'll go to Kelly.
Just a thought really about some of the wider changes that are happening in North West London as well. Whether we think about two things really. One is updating that sort of at the board, but also then thinking about the role of the board in those new arrangements, and whether rather than, so it makes it sound negative, but instead of having a lot of descriptive narrative about something that's happened or what we're planning to do, actually take some time to actually look into what the nutty issue is, or whether we plan in sort of workshops to do that. But I just think if we want to position ourselves as a governance type board, then I think we should probably be doing more of that rather than sort of hearing things that have happened, are going to happen, and noting them. And I'm not saying that it's important that we do that as well, but yeah.
I completely agree with that. That was the issue I was going to raise, Tony. So I think that will be just helpfully get us into inverted commas real discussions. I think which is what we need. So timeline on that, Tony. What would you suggest? That June next meeting feels like a priority to me. That one does. Yeah. Anybody else? Kelly.
Thank you, Chair. I just wonder whether, given that we are now a year into the the new health and wellbeing strategy, I wonder if we start evaluating what impact that strategy has had on the work that we're doing, with the measures that we've put in the strategy in terms of areas where we perhaps need improvement, where we've been an outlier, just to sort of refocus us back onto that document.
Okay. Any suggestion when we might do that, Kelly?
I think it's at the board's discretion as to. Kevin, when was the strategy published?
It was about a year ago. You're right. It's about a year old now. So June would work. I mean, I think we could bring some sort of an update. Gary's progress report covers part of it, but it's taking it back to the strategy a bit more to make sure it covers the whole. So I'd say we could put something down for June.
Okay, I think if we are following up Tony's point, if we are more radical around the agenda and we give more time to some of these strategic issues, we might be able to allow that discussion. So perhaps we can just genuinely just talk about that outside the meeting. I think that focus will help us. Anything else? Okay, I move that discussion be noted. Do I have a seconder? Yep. All in favour? Yes. Okay. So that is the end of the public part of the meeting. Thank you to those members of the public who are watching on YouTube. Will everyone please remain silent until Democratic Services has confirmed that the live broadcast has ended? Thank you.